Thank you so much for joining us this evening. The CMHC educational curriculum is scientifically independent and guided by our CMHC chairpersons, renowned international authorities on the spectrum of CVD and metabolic disease. Each program chair brings unique therapeutic expertise in specific disease topics, as well as extensive experience in clinical research and with leading professional associations setting the standards for the prevention and treatment of cardiometabolic diseases in the United States. Tonight we are very excited to have Chairperson Dr. Christy Ballantyne share his expertise in cardiometabolic health and highlight the curriculum that will be presented at CMHC West on March 4th and 5th in San Francisco. Dr. Ballantyne is Director of the Center for Cardiovascular Disease Prevention, Methodist DeBakey Heart Center, and received his medical degree from Baylor College of Medicine. If anyone has any questions during this webinar, please use your chat option. Dr. Ballantyne, I will turn the webinar over to you.
Thank you very much. I'd like to start off with a case which I think illustrates why we have started the Cardiometabolic Health Congress and also why we're doing the case out on the CMHC West. So let's start off with this. It's a 53-year-old white male with a family history of premature heart disease. His father died of an MI at age 50. He has a history of hypertension that's been treated with drugs for the last 6 years. He has a history of high cholesterol for as long as he can remember. He's a non-smoker. He walks 30 minutes 3 times a week. And on physical examination, his waist is 40 inches, his BMI is 28.6. His blood pressure on lisinopril and hydrochlorothiazide is 136/88. He's been on aspirin 81 milligrams daily, and he's been on max dose of atorvastatin 80 milligrams. Let's go to the next slide. So we've got someone, he's taking his blood pressure medications, he's taking his statin, he's taking aspirin. At this point, is it worth checking his lipids? Do we really need to do that? As you know, there were some new guidelines that came out. They were really focusing on statin therapies. And so there's some questions that get raised as to if you see someone for evaluation, do you still need to check their lipids? If he's on atorva 80 milligrams, are we done? So let's go to the next slide. And the other question that comes up is when someone comes in with a strong family history like this, is the lipid profile enough? Next slide. So any specialized lipid test. So let's look at the results from this patient. His glucose comes back 110. Now, his total cholesterol is 199, so that looks pretty good. However, as we look further in the lipid profile, we see some things that are more disturbing. The HDL cholesterol is low at 35 milligrams per deciliter. The non-HDL cholesterol is elevated at 164 milligrams per deciliter. The triglycerides are high at 180. LDL cholesterol is 128. His lipoprotein A level, and that was ordered because of the family history of premature heart disease, was 310 nanomoles per liter, which is elevated. ALT is slightly increased. AST is 30. So this is a pretty common patient. If we take a look at the profile, he's seen in your offices all the time. He's actually kind of thin for someone that we see in Houston. Our usual BMI in all of our lipid studies is around 31. But if we were to look at this patient and we say, have the conversation, is what are his major health risks over the next 10 years? The focus tends to be on risk for MI, but actually his greatest risk over the next 10 years is to develop diabetes. He has a very high probability. If we think about it, he's got the impaired fasting glucose, his low HDL, high triglycerides, the waist, probable fatty liver with an ALT of 48. So this person is pre-diabetic. And in fact, if you did a glucose tolerance test, you want to check an A1C, numbers might even be worse than we think for this. So number one is his risk for diabetes. The second is, in addition to his risk for atherosclerotic cardiovascular disease that includes both MI and stroke, is his long-term risk for having heart failure. It turns out that you can predict accurately, just as accurately, who will have heart failure. In fact, more accurately, we found in the ERIC study, who will have hospitalization for instance heart failure than you can predict for who will have a myocardial infarction. So this guy has got a lot of potential problems, and we have some major issues. And I think it's, if we look at the agenda, and I hope that you'll be able to come out to the Cardiometabolic Health Conference, the West Conference, is where do we stand on blood pressure now? What about the SPRINT study? How low should we go? George Brackus will be talking about that in our opening session. Does that apply to the person with diabetes? If this person has been diabetic, what do we need to do to reduce cardiovascular risk in addition to blood pressure, and are there other differences among glucose agents? He's on atorvastatin 80 milligrams. Well, that's increasing his risk for diabetes. So all this will be discussed somewhat in our first session, and we'll get into in terms of this person as someone who doesn't have diabetes, but the second session we'll be talking about slowing progression. Where do we stand with the future of GLP-1 therapies, or what are the options in insulin therapy? How do we put this into perspective with the other new therapies? And Jay Schuyler is going to close that up. So the opportunity of the conference is really, when we're treating this patient, it's not just the lipids. Yes, the lipids are an issue, but obviously we've got blood pressure, we've got his blood glucose, which is abnormal, and then we've got the obesity issue here. Let's go to the next slide. So we had our lipid guidelines. This person's on maximal statin therapy. Do you need to really check lipids? And actually, the answer is B here. They should be checked to assess compliance and response to therapy. Now, let's go to the next slide here. If we look back on this, he's on 80 milligrams of atorvastatin. His LDL is 128. So what does that mean? It means most likely his LDL was going to be, even if we don't have the prior labs, over 200. So this person, by that family history of premature disease and knowing his LDL levels, probably has, he was probably running 220 or 230, probably has familial hypercholesterolemia, and he also has high LPA. Now those are both hereditary. And so there's the issue of, in this person here, what's going on with his children? And when we treat the individual, we also want to consider prevention in the entire family when we're seeing genetic disorders. What about his brothers and sisters? Have they been screened for their lipids? What about their LPA levels? So this is very pertinent information, and we'll be talking on the second morning about some of the issues in regards to the updates about lipids. It's very controversial, as you know right now, triglycerides and HDL. What are the targets? How do we use imaging and biomarkers? And so Matt Budoff will be going over that. Sergio Faggio will talk about triglycerides, LDL, cardiovascular disease, and I will be talking about where we're going in the future in regards to some of the targets here. There'll also be Jamie Underberg will talk about familial lipid and metabolic disorders. There are some other things to consider besides FH, although this is certainly the most common one. And then there's also going to be a perspective in terms of how we can look at big data and lipid management, finding FH, and novel things that are going on in regards to using informatics to identify these individuals. Let's go to the next slide. Okay, so the patient now has, he's taking his medications. Now we skipped over one slide here. Can you go back?
Sure, just give me 1 minute.
Yeah, he was told basically at that time to exercise, lose weight. You know, it wasn't clear what to do. So he basically ended up getting some, going to see someone else and got some other labs. So if we can go back and show what those slides were for it. While we're waiting, it turns out that he ended up getting a coronary calcium score too, because he's very worried about this family history of heart disease. And as shown on this slide, his coronary calcium score comes back 677. And that's where we'll get some of the data from Matt Budoff. What does that mean in regards to this person's risk? Putting that in perspective, risk for MI. And there's also comes back his LDL particle concentration's high. He's got lots of small dense LDL particles. ApoB is high. So he has a high load of atherogenic lipoproteins. And now it's not just looking at consideration of someone who might have atherosclerotic cardiovascular disease. He has basically asymptomatic but subclinical coronary artery disease. So next slide. So how does this change things? He's a high-risk patient. He's got there's lots of atherogenic particles. What do we do with this type of a patient? We don't have the outcomes data, but there are some novel approaches, and all of that will be discussed. Now, the other part on this patient is, what about his lifestyle? What about the weight? Let's face it, this is someone who, yes, he does have a hereditary disorder, but he's also got some issues in regards to likelihood for developing diabetes and then also his obesity. And that's a critical part of the management of these patients who have increased cardiometabolic risk. Our final session on the second day is going to focus on obesity. And one of the things that comes up is what we've always been telling people is that diet and exercise make a big impact, and it goes beyond weight. It really goes to the function, basically adipose tissue function. And what we see now, it's far more complex than just weight. Changes in diet can rapidly change the gut microbiome. And that's some really fascinating data that Peter Turnbar will be discussing. Harold Bays will be discussing about how genetics and epigenetic factors affect weight. And Sam Klein will put together some progressive approaches to obesity management. How do we integrate diet, exercise, and pharmacotherapies? Now, the other one that comes up is this issue of the role of bariatric surgery in metabolic, basically, improvements, which have been striking. And then there's lots of controversies that you've all heard about that come with your patients in regards to what's the real issue about dietary fat and cholesterol. Eggs and bacon, is it true that you can eat as much as you want? Ron Krauss, who's been a leader in this field for many years, will talk about putting this new dietary information together. Next slide. So in summary, I went through briefly the type of case that shows up in our daily practice. But what we're hoping to do at this conference, and one of the things that's so enjoyable about going to these is that the meetings are smaller. If you go to the American Heart Association, the American College of Cardiology, the American Diabetes Association, you spend all your time running from room to room across big convention centers. The good part of that is that, yes, you get a lot of steps in. The bad part of it is that you're running around like a chicken with your head cut off, and then you don't really have a chance to ever talk to the speakers because they're running from room to room also. This is a smaller meeting. At this meeting, we talked about, we're going to get into some of the newer data. How do you apply genomics, lifestyle medicine, big data, some thoughts about patient engagement, motivation. Show the next slide. And then there's an opportunity to meet and talk to these individuals. I mentioned some of the names, but some of our keynote presentations. Bob Harrington will be there, talk about the new era of big data, precision medicine, and digital health. And Peters will talk about novel technology, apps, and innovations in diabetes management. Particularly important, I saw a patient today in clinic. He is just terribly frustrated in regards to how he's doing in regards to his diabetes control and his weight, and anything that he wants to do. Well, what's new? What can I do? And it turns out there's many things that he's been treated with in the past that he's never tried. And I think one of the things we want to do is offer our patients new approaches. I mentioned this fascinating new science about the gut microbiome and cardiometabolic health. Peter Turnbull will be here to share this new data, which has major clinical implications in the health of our patients. Next slide. All right. So let's go over, I put a case in here. This was someone who didn't have diabetes, pre-diabetic, but obviously if they're diabetic and they're on a couple of medications and not having great control, it makes it even more complicated. So 5 reasons to attend the CMHC West. Discover practice-changing clinical updates that will elevate the patient care that you provide or your group provides. Gain valuable insights on trends and current controversies in CVD and metabolic disease management. Obtain real-world perspectives on how to manage complex patients and overcome common barriers in your practice. Connect with our renowned faculty, your colleagues. Get your questions answered, share ideas and experiences at the breaks. We're available to discuss the presentation, but also if you've got a case that you have a question about, or it might be your own personal situation, great time to grab the faculty members. What would you do in this case for this patient if you were seeing them? Experience firsthand and learn from cutting-edge products and services featured in the CMHC exhibit hall and professional education sessions. The nice thing about small meetings is that you're able to attend all of the sessions. We have breaks at which time you can go to the exhibit hall. They've got all types of interesting exhibits. And when you're there, you can meet the other attendees, also the speakers, and at the same time have a chance to look at the exhibit. So after having done this for the last 10 years at various settings, I've seen more and more that the attendees truly enjoy a smaller, more intimate meeting where you get to have great science, but also have a little bit more interaction and collegiality, and in something that we think is done in a manner that's very practical and gives things for you to implement in your practice when you leave. So I hope to see you at the CMHC West meeting. Thank you for listening, and come to the website, look at the information, and once again encourage you to attend this meeting. If you can't make this, we'll have the meeting in Boston. In addition, we're having some regional meetings, so come to the CMHC website. It'll keep you up to date in terms of what's available, and once again, I hope that you'll attend. It's been my pleasure. Thank you.
Thank you so much, Dr. Ballantyne. We do have a special announcement for the attendees on the webinar tonight. We are presenting you with a $100 discount off of your tuition for CMHC West. You must reserve your spot by Friday. The direct line for you to call is 561-777-6807. We truly do wish you will be able to join us for the inaugural CMHC West focus on novel approaches to integrative cardiometabolic disease management. This again will be on March 4th through the 5th in San Francisco. This unique forward-thinking program will feature innovation and advancements in lifestyle medicine, therapies, technology, patient engagement, genomics, and big data are the driving improvements in outcomes, quality and CVD prevention. Apply new solutions and change your practice. We look forward to seeing you. Again, thank you so much, Dr. Ballantyne. Everyone have a fantastic evening.